Well, two more sets of terms that are often troublesome as value-based care increases focus on measuring quality and cost of care are the terms measure versus metric and baseline versus benchmark. It's important to define these terms because throughout the discussion in this lecture, we've alluded to various reporting of quality and or process measures, quote unquote, and using benchmarks to make financial decisions. The terms measure and metric are often not used as precisely as they should be, and many use the terms baseline and benchmark synonymously when they are not synonymous. So, measure is a term that may be either a noun or a verb. As a noun, measure is a size, amount, or degree of something. As a verb, measure is the process of determining the size, amount, or degree of something, often requiring an instrument with standard units, like a goniometer or a ruler. A goniometer is a device that measures range of motion. Other examples, as I said, are rulers, scales, thermometers, and many, many others. Such devices generally answer the question, how much? On the other hand, metric is the standardized description of what will or should be measured. For example, range of motion within 3 months of joint replacement surgery, or body temperature using an oral thermometer for adults unless contraindicated. That's the metric. As a standard, a metric enables precise comparisons. Unfortunately, more often than not, the term measure is being used to both describe not only how much, but also what the metric. And this often results in lack of adherence to a standard metric because the metrics are subsumed in the process. Closely related to measurement using appropriate metrics are the terms baseline and benchmark. When you take a measurement of something using the appropriate metric, you have data that tells you how much according to what standard at a point in time. When that measurement is an initial measurement from which you want to measure improvement, that initial measurement is referred to as a baseline or baseline measurement. If a person is undergoing joint replacement, an orthopedist generally will measure the patient's range of motion in the joint and document that. Following the surgery and during physical therapy, range of motion will be measured at given intervals and compared to the baseline to ascertain level of improvement. To determine that the joint replacement is successful after the normal recovery time period, however, a benchmark or industry standard should be the comparison. Such measurements are very important to determine whether a joint replacement surgery has been successful or not. In fact, the amount of payment for a specific joint replacement bundle may be incentivized not only by a set fee for the surgery and physical therapy combined, but based on the final outcome as measured in accordance with a standard metric and compared to a national benchmark. So, obviously, terms have important nuances for value-based care. What may or may not be obvious from the discussion thus far is that value-based care is more encompassing than traditional medical care. So really we need to talk about the difference between medicine and health. The term medicine and medical care generally refers to a practice wherein a person, typically a physician, tries to diagnose and or cure an illness or injury, prescribes drugs, and performs surgery. Medicine assumes a state of illness or injury, that is, some absence of health. While follow-up care by the physician following a treatment regimen is generally included in the scope of medicine, physicians have neither been accountable for or helped assure that a patient keep follow-up appointments. Other forms of care services relating to the illness or injury necessitating the initial diagnosis and treatment process, such as physical therapy, rehabilitative services, prescription drug therapy, etc., have often not been considered within the scope of services provided by physicians, even though most of these services require a physician authorization, such as a prescription. Even when a primary care provider, PCP, refers a patient to a specialty physician, such as a cardiologist, neurologist, etc., there's no accountability to the primary care provider for the patient actually being treated by such a specialist. And certainly if the patient fails to get follow-up care or specialty care due to lack of transportation, cost considerations, or other factors, there's been no accountability levied on any provider for such help. So where medicine implies a state of illness or injury, some absence of health, health relates to the condition of being sound in body, mind, or spirit, especially freedom from physical disease or pain. Health is considered the normal state of the body and can be aided by an infrastructure of clean water, proper sewage, prevention of pollution, etc., considerations for which are generally considered under the domain of public health. But more recently, health includes a lifestyle that reduces risk of illness or injury, such as healthy eating, proper sleep, etc. Medicine traditionally has not promoted health by addressing these factors directly. Under value-based care, however, coordinating care with follow-up services, specialists, and even public services such as transport services, Meals on Wheels, social service agencies, etc., are becoming important. These factors are often described as social determinants of health. Just how much of this can and will be done and accounted for as financial risks shift remains to be seen, but we are seeing the start of this process. Another set of terms I think we need to distinguish between in value-based care, difference between patients and consumers. A patient is generally a person who requires medical care, is receiving such care, or is waiting for care. There's no explicit or implicit assumption that the patient is at the center of everything that has to be done. Alternatively, consumer is an individual who uses products or services, and sometimes we distinguish customer from consumer. Customer being an individual who can and does make a buying decision. Sometimes they're one and the same, sometimes they're two different people. Treating patients as consumers is a growing strategy. It is a headline of a recent article describing the current trend toward consumerism in healthcare. Much as the practice of medicine is broadening its focus on health, the healthcare system as a whole must become much more consumer-driven. What is becoming increasingly important is customer service, and that is the experience of care as part of that CMS triple aim. Price transparency, especially as patients are paying a much greater percentage of the total cost of care. And when we don't even have prices for services, this is going to be tough. And quality outcomes where patients are more likely consumers in wanting value. They want to know, if I have to pay this much, what am I getting out of it? There are many factors influencing the shift to a consumer-driven healthcare marketplace. Some of these are the increasing cost burden on the customer, but many of the factors also relate to rising patient expectations and widely available competitive quality and cost information as social and media expand customer reach way beyond the traditional coffee clutch. Technology advancements in many forms are enabling patients to become more informed consumers. Consumers are also becoming much more demanding in their experience of care that requires them to be the center of attention. It has been noted that the model for exceptional customer service is not necessarily found in healthcare. Healthcare must look to operating much more like the retail industry, where shoppers can shop at any time of day or night, compare prices, and receive goods nearly immediately. Amazon? Stronger engagement between physicians and patients is also essential. Many, though, it is recognized that not all, certainly yet anyway, patients and consumers want to at least share in, if not fully direct, decision making about their health care. Physicians and all other health professionals need to be able to read their patients' consumers better to understand what their needs are. Many health professionals describe patients as having little health literacy, but increasing numbers have by far more than what most professionals assume, and may need a far different communications approach as a result. And if patients are not health literate, they generally need by far more help than is normally provided. Much like precision medicine using genomics to target specific treatment to a specific patient, more precision in the overall healthcare delivery is needed. In summary, if value is an economic concept of quality and cost, medical practice would do well to take applicable lessons from economics and apply them to creating a valuable health system in order for value-based care to succeed. I look forward to continuing this journey with you in the next unit that will look more closely at the components of value-based care and the leadership needed for its success. And don't forget to check out the references on the next slide and to take your first assessment. As I noted previously, the references listed here were used in compiling this lecture. The links, again, as I said before, may be broken, and I'm sorry about that, but do try to access via the name of the article. You may also wonder why I've departed from the standard format for citations in the reference list in this MOOC. This is because I think it's helpful to consider the topic of the references over the author at this point and for this purpose. This may reinforce the concepts discussed in the lecture, as well as possibly entice you to check out a few of the articles for further information.